Ladies and gentlemen, the webinar is beginning. My name is Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council, and we want to thank you for being here today for this educational webinar hosted in coordination with OnPoint Healthcare Partners. They are an associate member of the Hospital Council. OnPoint Healthcare Partners serves as a transformative agent that enables improvement in healthcare by providing collaborative solutions to help bend the cost curve. Today's topic is Get Back Time and Joy of Practicing Medicine with Iris, Virtual Clinical Assistant. Our speakers are going to detail the new Iris Virtual Clinical Assistant, which is an innovative tool. It eliminates the burden of administrative work and documentation duties so you can spend your time and focus on patient care while enhancing the quality not only of information but in the capturing of data. The Iris Clinical Assistant is virtually present in the exam room and preps the physician prior to the encounter with the patient. It can document and code clinical notes, pinned tasks, help with orders and wellness updates, and submit referrals and prior authorization requests directly to the EMR. We're delighted that we've got two excellent speakers today. One is Jim Boswell, President and CEO of OnPoint Healthcare Partners, and Rodney Haynes, Chief Operating Officer at OnPoint. Jim has worked in healthcare for over 25 years, served as Vice President and Chief Development Officer at IKS Health, which is a global management services organization, and former President and Chief Executive Officer of the Baptist Medical Group, which is a nonprofit subsidiary of Baptist Memorial Healthcare. We look forward to their presentation and are excited to have them with us today. It is my pleasure to introduce Jim Boswell and Rodney Haynes, and I think I'm turning it over to Jim. So Jim, thank you so much.
Thank you, Steve, and thank you, Chris, and thank you for Dallas-Fort Worth Hospital Council for joining us today. We're very excited about being here and sharing with you many of the innovations that we have to offer medical groups and health systems in the Dallas-Fort Worth area. I first just want to mention OnPoint Healthcare Partners is a physician practice management and solutions company. Our background is heavy in operation and physician practice management of large multi-specialty group practices, both within health systems as well as independent medical groups. We are in the last mile, we call it, of creating solutions and that really have an impact on and moving the needle for our clients. So we're happy to be here today, and we're going to take you through Iris Virtual Clinical Assistant, which is a solution that we have deployed around the country that really gets us excited because it's returning the joy of medicine back to physicians and the care team. So I'm going to ask my colleague Rodney Haynes to start us off, and then we're going to be the two of us will be walking through this presentation, and we're going to do a demo for you, as well as talk about some of the real tangible sort of impact that this solution is having to large health systems and medical groups around the country. Rodney?
Thank you, Jim, and thank you all for attending today's webinar. Really appreciate you giving us the time today as we go through this material. So we'll go through a brief set of slides and share some information with you, and then I'll hand it back off to Jim when we get to the slides specific to the solutions we're going to be talking about today. So the question that I think is a logical place to start our discussion today and our interaction is around why we're here. Not just why we're here in the webinar, but why are we here as a set of healthcare providers in the country trying to make an impact in our communities and create efficiencies in our clinical and operational and financial workflows. And what I think has been pretty commonly experienced across the nation is what we see on the screen here today, and that is, clinicians experiencing substantially increased work hours, specifically within the EHR, not necessarily increased access hours for patient care, but certainly additional hours during the day dedicated to the documentation process at night and on the weekend to catch up to the volumes of the day. That administrative burden and the impact of working in a computer as opposed to making clinical decisions has had a negative effect on access to care for patients, growth in patient panels, and as a byproduct of that, reductions in productivity, revenues, and overall sustainability for the medical groups. I think everyone in the webinar today has probably read multiple articles at some point in time or been to conferences where the topic of physician burnout, provider burnout, clinical team burnout, that term gets bandied about quite a bit. But we were reading an article recently, and they addressed this concept of burnout in a different way, in different phrasing, and they addressed it more in the lines of moral injury, which is, it's not that docs aren't able to overcome the challenges that are in front of them. They go through, in many cases, decades of training and experience to get, really hone their craft, and their craft is people-centric. And yet the work that they're doing on a daily basis is very data entry driven. And the net result of that is there's this disengagement and disenfranchisement of physicians for the work that they're doing relative to the work that they want to do. We consider it a key aspect of our organization to dive into those workflows and solution for them ways to recreate the joy of medicine and get back to the care of patients and not data entry workflow. So one of the common questions that comes up when we're in a presentation like this, or we're having conversations with systems around the country, is, what's the niche, what's the target organizational structure that OnPoint is here to address, and what are the specific areas of support and solutioning that we address in that. This slide that you're looking at on the screen right now, down the left-hand side, working with systems that are large integrated health systems, academic medical centers, independent medical groups, single specialty, multi-specialty, private equity platforms, and MSO services around the country. We work with all of those entities on a daily basis. Down the right-hand side, you see some of the more specific and narrowly defined areas of clinical workflow that I referenced in the prior slide. These are the duties that our clients and our colleagues around the country are telling us that their physician and clinical teams are struggling with. So everything from clinical note creation to coding, prior authorization workflows, document management in volumes that come in paper in their clinic in a day, referral management, prescription management. These are the kinds of things that they're stating are driving all of this data entry in their computer systems. So as I referenced, we work with these various entities around the country. Right now, we're supporting about 937 physicians, doing daily chart volume of about 6,600 charts, using clinical support staff from our organization of about 858 people, with about 408 of those being scribes dedicated to the process of clinical documentation. We do that work, as you noticed on here, the colored states, the ones that are in blues and grays. Those 32 states are the states in which we support and provide services today. With that being said, the service that we're going to focus most of our time on the remainder of the webinar today is something we call IRIS, which is a virtual clinical assistant. The nature of this, the reason that it's referenced as a virtual clinical assistant is because the workflow that's being done here is much more robust and strategically and intelligently designed from a support standpoint. It's not simply a note creation workflow, it's an administrative burden reducing workflow. So we'll go into that and look at some of the unique aspects of IRIS. Jim, you want to speak to this one?
Yes, just to pick up here, our IRIS is delivered virtually in the exam room by use of an iPhone or an Android tablet. It is encrypted and compliant with HIPAA and multi-level military grade encryption. It is integrated with the physician schedule or the provider schedule with the EMR, the practice management system. We can do this in real time, or we can do it on a delayed basis, next morning or a couple hours. It's really fairly straightforward to customize this for our clients. We're EMR agnostic. We do this in an Epic environment, Allscripts, Cerner, eClinicalWorks, you name it. English and Spanish, so we have the capabilities to both within even within the same provider, within the same day, we could do English or Spanish, depending on what the client or the patient is their native language. We are using artificial intelligence and machine learning, but we don't want to leave you with the thought that this is magic, where we're literally taking a complex human interaction between a doctor and a patient and converting that to note and doing the coding, et cetera. We have clinicians that are doing that work that are enabled by the technology. We do this in an inpatient environment as well as outpatient. So inpatient hospitalists, we're able to deliver some fairly significant productivity gains and revenue gains on a hospitalist environment as well as outpatient. And we're also a telemedicine enabler, where we can literally combine up with the telemedicine platform and be able to deliver and make some significant productivity gains there as well. So this is one of our more favorite slides. Most of us are on the line are going to be very familiar with this story. To the left is the physicians today before IRIS. They are tasked with doing the note after the visit, or in some cases during the visit. They're doing coding, they're doing tasks, they're doing orders, referrals, and any kind of chart updates, as well as changing scripts. The challenge here is our data and is showing, as well as one very large national or top-rated healthcare delivery system, it's clearly the data is showing that physicians are spending really about 50% of their time in the record. 50% of patient care time is spent on the record, and that's been documented in many environments. And what we're going to show you today is how to the right, how we can take those tasks, those orders, doing that note, doing that coding off of the provider, and really have an impact on productivity and revenue and frankly quality of life. Won't spend too much time on this because we're gonna go into a demo and you're gonna see this firsthand. But I would want you to see is that we're gonna specifically talk about performing the note, doing the coding, and doing the referral, processing the prior auth. So we're gonna talk a little bit that in our presentation. Okay. Okay. This is one of my more favorite diagrams. Let me tell you why. We all know as administrators and healthcare leaders that what's coded has to be documented, and we all know that in many cases physicians are undercoding. Well, I'll tell you what we have learned is physicians underdocument. They simply do not have the time to document. And because of that lack of time, If it's not documented, it can't be coded. And if it's not coded, it won't be paid, of course. What we have found through the use of Iris is we have significantly improved what's documented, because we're doing the documentation with Iris. That's our single job here, is to get this documentation and to support the physician or the provider through our virtual clinical assistant. That's our focused job, and therefore we do a very good job of delivering a high quality note and taking a very complex human interaction and translating that to a SOAP note or an APSO note. We are not a transcription of services. We do translation services. So we do have clinicians that are translating that conversation into a note, and our physicians love the quality of the note, and most of them believe it's as good, if not better, than their own. So I want to show you here a little bit. Sorry, I went a little fast there. We're integrated from the schedule all the way through the final note. So we will, as I mentioned, we'll integrate with the schedule. The doctor, I'll show you in a moment, the doctor will click on the note, their schedule, and then pull up, and then as they move throughout their day, they simply just have to keep following their schedule, which gets updated as work-ins come in, et cetera. We'll do chart prep. We have templates built into this. We do task and orders and pin those for the physician. And we'll also do coding, both HCC as well as E&M and CPT. And then we deliver the final note to the doc. Here is a diagram for those that are workflow experts. Here is a diagram that really separates out what the nurse does versus the physician and versus our Iris. Notice that all of these darker gray areas are what the physician has to do. The physician conducts, the provider conducts the visit, and they sign off on the chart. The nurse is going to room the patient, capture the vitals, and then Iris is going to apply the template. We're going to enter the task and the orders. We're going to document the note. We're going to recommend coding, and the doctor is going to review it and sign off on it. This process typically takes the physician anywhere from 10 to 15 minutes. We're reducing the time that they're in the chart by 80%, is what our data shows. So we're significantly adding back the most valuable asset of all, and that is time, giving that back to the physician as well as the care team. So with that being said, what I want to do is we're going to go into the demo. First, I want to show you the tablet. What you're looking at here is what the doctors see, the provider sees. We would like to show you today two aspects of Iris. We want to show you what the doctor sees, and then we want to show you sort of the way the sausage is made behind the scenes here. So this is an iPad, and the doctor carries it into the room. It fits in their white coat, or the nurse may carry it into the room, etc. It's linked to the schedule, as you can see. The doctor clicks on the patient, hits start. It automatically initiates a live streaming or recorded streaming, however we choose. It initiates that, and then the doctor sets it down and conducts the visit. Conducts the visit in a manner that's very natural, and they're not on a keyboard. They're not having to call out special words in order to have the computer convert this. They just simply conduct a visit. It is not dictation. It's real important. It's not dictation, because we don't want the doctor to do anything different that's not natural to them. The doctor can pause if there's something very confidential that needs to be mentioned, or if they're called out of the room for some reason, they can pause. Once they hit start, or once they hit end, this live stream, our scribes, our clinical team, will document that note. And once we document that note will show up in the physician's electronic medical record, whether it's Epic, Cerner, Allscripts, it doesn't matter. We will put that note in there, and the doctor will spend on average 1 minute reviewing that. If it's more than a minute, then frankly, at that point, we feel like we have failed. because we don't want the doctor to spend much time editing this note. We want it to be essentially perfect for the physician. And I know as all my colleagues out there, they do as well. I want to make sure that they're bringing a very high quality service to the physicians. So this is all I want to reemphasize. This is the only thing the physician sees. And it's very, very technology wise, really simple. Now what I want to do is show you what it looks like to our clinical team that's doing the actual note. And let me explain first why that's important. We have experienced, as we show this to our clients, they understand more how this works if they have a glimpse into the behind the scenes. So I'm going to take you there now and show you behind the scenes what this will look like to our clinical team that's doing the note. All right, so let me go into that right now. So I'm simply going on to our web page, and what I'm showing you here is Donald Trump just sent me an email. What I'm showing here is the job screen basically, and as I mentioned, we use AI, and it enables our clinical team to document the record. What you're seeing here is the voice to text transcript that is a result of that complex human interaction I mentioned. It's not perfect. We don't have the computer completely trained here, but it does a really good job of creating a transcript between two people that are talking. It creates the transcript, and from that transcript, as we're listening, the note is created using a SOAP note format or an APSO format, where we review the systems, physical exam, etc. I also want to note that if the physician is calling out, changing meds, follow-up appointment, etc., we are capturing tasks and orders such that I mentioned that bubble diagram where the physicians are, we want to take off that work off of the physician and the provider. What we don't want is for the provider to have to walk out of the room and have to capture, grab a nurse or grab someone at the front desk and do 4, 5, 6 different things. We want Iris to pick those up, and we want to minimize as many handoffs as possible so that the physician or the provider can go to the next visit. So I'm going to play you for a moment how this works, because this works very well. And I'm not going to take you through a 4-minute visit, but I will show you how this works and how it scrolls through the conversation in a mock-up visit, and how I'm also going to show you how easy it is for our clinical team to go between paragraphs so that they can listen more to what's going on. Okay, so I will tell you that it might be a little faint, so please listen closely. We had a little technical problems earlier, but here we go. This is a mock-up visit. There's no PHI here, of course. Let me just go through this. Okay, here we go.
Hey, Mrs. Jones, it's good to see you again. It's been a while, huh? How's John?
He's great. Thank you for asking.
Great. Well, I think it's for your 20th wedding anniversary, right?
That's right, it was.
Well, I think the last time we saw you.
That's right, it was.
Okay.
So as I said, I won't take you through the listening to a patient visit, but I did want to show you how this helped. It's been our experience that scaling is critical here, and to be able to add hundreds of physicians onto this program, and the efficiency of our team, our clinical team, is extremely important. So we've built this out for that efficiency, as you can see, they can navigate through this transcript. Also, they can list all the different problems and all the pertinent positive and pertinent negatives. They list all this in discrete fields, and then they go to the final note. And the final note this is the way this final note will show up in the EMR. It's done very professionally in the way in which a physician would typically want to see this note, and it's put into the EMR. There's nothing the physician or provider has to do. So that's a little bit about, not to spend too much time, but that's a little bit about how the sausage is made in Iris.
You want to talk a little bit, Jim, about the quality measures that were put in?
Yeah.
Task orders and recordings.
Yeah, Rodney has pointed out, I think, as I mentioned, as we listen to the encounter, things are vocalized. And those things that are vocalized, it's real important that we capture those. And for example, you can see right here, her husband smokes, so we're going to update the social history. So see, we go in and update the social history, or we add pneumonia to the problem list. When we have tasks and orders, we check those off. We understand how important it is that if we're going to take responsibility for something and that it gets done, and we report on these things to ensure that we close the loop. The other thing that we've built into here is quality. There's a quality algorithm built into here such that the notes are reviewed by physicians. I mentioned that we have clinicians, we have some non-physicians that could be created, that create the note, and we have physicians that are our quality check. So the quality of this note is rather substantial, and as the administrative and clinical leaders on the phone, you don't have to worry about the quality of the note letting you down in any fashion. I'm going to show you an example here of the quality of the note here. Let me go back to our presentation, guys, or where is that? Right here. Okay, so let me go back and show you this. We've gone through this, and this is the screen we just looked at. Here is a final structured note, which is an outpatient visit. And as you can see, there are 4 different problems. This is the same visit we just listened to. There's 4 different problems. It can be formatted this way as well. What I want to show you, we mentioned that we do this on the inpatient basis. And for hospitalists, there's no PHI in this, but I do want to mention, look at the amount of medications that this particular patient is on, and look at the 20 different problems. So this is an LTAC, and this is a hospitalist that is seeing patients in an LTAC, and this is a fake patient that we created. But you can see the amount of how robust it is, and it's actually disguised because it's actually a real patient. So that gives you an idea of the quality of the note. I mentioned there's 3 things we're going to talk about: the note, the coding, and prior authorizations. Those are 3 out of 10 services that Iris can deliver for your physician or your providers. I won't spend a lot of time on this, but since we document the note, we know what happened remember those circles that I mentioned, we know what happened in the exam room, we know what was delivered, we documented it, and now we can provide really good coding advice to the physician who ultimately signs off on the note and signs off on the code. We call that concurrent coding. We can also, because we have certified coders that are doing it, we can also provide alongside that E&M coding, we can provide HCC coding in a value-based environment. So we can deliver coding. We can also deliver prior authorizations. Now we all know how painful this is. Prior authorizations is a substantial heartache and headache on our care team. We all know we have nurses and other clinicians, and we have some central teams that are spending a lot of time on prior authorizations. 90% of prior auths are being done manually today. We have built in technology here where Iris can deploy, and we can go in and really significantly automate prior authorizations. And I'm going to walk you through only 2 charts here to give you an idea. But first, just to make the case, this is some data there's been quite a lot of research been done lately on prior authorization. That research is showing that it's cost about $15 per manual prior authorization. Gives you an idea of how much time your staff is spending on it. 91% of the physicians are just reporting this. It can delay care. There's a significant number of denials that can be related to authorizations. And then most folks are reporting that it's getting worse. Now, we all know there's some talk about standardization, et cetera, but we have the technology to be able to submit these prior authorizations and report on it and significantly reduce the burden on your team. So we can, just to connect the dots here, if we're listening into the exam room and we hear that there's a referral needs to be made and there needs to be a prior auth from that, we can kick off the prior authorization. Once the order has been signed off by the physician, we can kick off the prior authorization request and get that ball rolling such that we can reduce this amount that's being done manually, and it can be done electronically. Let me show you just one more diagram on this. We pull the information out of the HR, goes directly in our technology, which is linked in with ours, and we can submit the prior authorization for all payers and all services, whether they require a fax submission or whether you access that you submit your prior auth through web portals, or you have to get on a phone. If you have to get on a phone, we have the resources to be able to bring the team to deploy experts in this area, or we can train your people to do this in a central environment, and be able to minimize the amount of folks that are on the phone because we maximize how the technology submits. We get the authorization verification, and we push that back into the EHR. Our technology partner that we've partnered with here is in Epic's Orchard. They're strategic partners with Allscripts and with many other platforms around the country we are strategic partners with. So there's a significant amount of efficiencies that can be gained by deploying Iris with coding, note creation, and prior authorization. Just those three alone, plus task and orders, can have a significant impact on your provider's productivity and the revenue. So let me go to that. Let's go to what the outcomes are. What do we see? And this is very familiar with for most folks, and that is the quadruple aim, something that's at the top of our focus in our organizations and pillars that most large health systems certainly are focusing on, and impacting the patient experience, the physician care team experience, the quality of care, and the cost of care are obviously top of mind awareness. So how does Iris enable these things? Well, I will tell you that Iris has a significant impact. Let's just look at this lower right quadrant. Iris and the related services that we provide significantly reduces physician documentation. As I mentioned earlier, physicians are spending roughly 50% of their day in the EHR, whether it's notes, coding, task, or orders. And then there's, on top of that, they're spending 2 to 3 hours at night. Those of our listeners that are Epic, they're familiar with the infamous pajama time report that shows that physicians, our clients are showing 2 to 3 hours a night. We can reduce that by 80 to 90%, essentially eliminate it at night. And the physician should spend all but 1 minute in the EMR signing off on the record, and the note and the task and the orders after they've reviewed it, et cetera. We improve the note consistency, the quality of the note. We're improving the coding and the compliance, and at the same time we're reducing the physicians' frustrations and their burnout or moral injury, as Rodney mentioned earlier. And then certainly we're improving the work-life balance. The patient experience, we have some of our clients that have documented patient experience using this technology, and we're seeing a significant improvement. Patients feel like the doctors are speaking to them, and they are, but they have to provide more clearer assessment and plan, and patients are feeling like and are reporting that clearer assessment and plan and is communicating, improving the communication with patients, which we all know will happen. I mentioned the quality and the accuracy of the documentation and an improvement in the capture and the coding all leads to improve. And then we're also improving access. Let me go to another ROI slide, because we get this question a lot. What is the ROI? And I just want to bring it right down to the physician, the provider, and the physicians, the impact here. Of course, Iris touches, as I've mentioned, across the clinical, financial, and operational aspects of providing care to our patients. What we're seeing is on the revenue side, because of improved capture of the note and documentation and improved coding, we're seeing anywhere from a 10 to 15% improvement in revenue. We're also seeing the improvement in productivity. Now, frankly, some doctors will take this to quality of life, the extra time they're given to quality of life, which is a good thing, but they also will see more patients to be able to pay for the service and, frankly, to provide access and increase their panel. We're seeing that this is within the control of the physician, that they're being given back all of this time, and how they choose to use that time varies. But it's as much of what the organization's relationship and expectations and the physician's expectations. That's really what's going to be driving this. So I think that gets us about to the end of this, and I think we can open it up for questions, unless Rodney had any comments to make.
Oh, that was excellent.
Okay, well, let's open it up to questions, Steve, if you don't mind.
Yeah, Jim, we've got a couple of questions that have come in, and I know you touched on some of this, but maybe to expand. One question was, we have proceduralists on staff. Does this service support all specialties in all settings?
Yes, and thank you to that for that question. The truth of the matter is that any provider that is creating a clinical note, a clinical encounter note, can benefit from this technology. I think Jim referenced in one of the earlier slides that the service is deliverable in the inpatient setting and the ambulatory setting. So whether it be hospitalists, surgeons, medical subspecialties, certainly primary care would be huge beneficiaries of this. But even beyond that, in some organizations that we're working with, we're having conversations in the home health and nursing space. Anywhere that a clinical note is created, we are providing the support for them. This service was originally designed in an ambulatory setting, primary care, internal medicine. So that's where it got its origins. But what we've done over time is perfected the tool and the support mechanism such that we can step into any specialty in any environment where a clinical note is created.
We've got a second question that has been submitted. And again, I know you touched on this in the presentation, but this will kind of put a real focus on it. How does the Iris Scribe service compare to other live scribe or dictation services in terms of, in your opinion, the note quality and the workflow?
Yeah, that's an excellent question. This is Jim. The note quality is everything. It's extremely critical that we deliver a note that physicians feel as though is reflective of their work and their expertise. So we really focus on that. Our note is of really high quality because we're using clinicians to do it. What we have seen with some other services is it's a dictation. Nothing wrong with that, but it's been our experience that physicians don't really want to walk out and dictate and really simplify the note, what they're just able to recall. In many cases, we're able to pick up things to physicians just comment to us they're glad that we picked that up. So that tells you that they may not always be thinking about it, and they certainly don't in their dictation cover all of that. And the other thing is we're using clinicians as well as the quality assurance side of this, where we're using physicians to check our notes from a quality check. So the clinical, what we call beautifully synthesized, the clinical synthesization of this note is really important. So thank you for the question. Good.
Yeah, we've got another question here. You know, this is a person who works in a clinic and said, you know how busy physicians are and the clinicians are in their schedules. While this looks very good and very interesting, how much time and effort is it going to take to implement this?
Yeah, absolutely, Steve. Thank you. So this is Rodney again. You know, our experience has been that our team will spend somewhere on the order of 2 to 3 weeks doing a fairly robust analysis and review of the clinicians' documentation preferences and their practice, you know, common elements of their practice and their note creation. So we do a pretty significant amount of learning before we go live with them. But we typically put providers on a 3 to 4 week ramp to full go live volume. And that means that, you know, once a provider is identified they want to go on the service, within a couple of weeks, we can be on the ground and deliverable. We ask in the first week for them to do 2 to 3 notes a day only, just to get in the habit of comfortably using the device and, you know, moving to more of a verbal delivery of their clinical encounter. And then after that, the next week, we ramp them up at their comfort level to somewhere on the order of 40 to 50% of their normal volumes. If the provider feels comfortable at that point, many times during that second week, they'll ask us to go ahead and go to full volume delivery. We typically would like to do that somewhere along the 3rd to 4th week before we go full volume and we're handling every one of their encounters every day. So, you know, every provider is a little bit unique in their adoption of new technology and new solution support as Iris represents. But the one common thread that runs among all of them is once they get converted to the solution and the technology, they never want to go back to creating those notes themselves again. That's universal.
You know, the other question that I have, and this is a question I've got, this didn't come from one of the people that are on the webinar. I was just thinking as you were going through how technically savvy this is, could this be adapted to help physicians in COVID-19, in virtual visits and telehealth and those kinds of things? It seems to me it would lend itself pretty good for that.
Yes, sir. Your instincts are exactly correct there. Whether it's an in-person visit or a virtual visit, IRIS can significantly reduce the burden of documenting it. It's actually, if you think about it, if a doctor is providing that visit virtually, then having to go out of, from one place in the computer to do the visit to go into another place and document the record, it's just as difficult as it is on an in-person basis. In fact, we have a client, a large client that we're talking to right now that has approached us for exactly that use case, Steve. They're having some real challenges getting their physicians to maintain their productivity in a situation where at COVID, there's more and more demand on virtual, and they're having a hard time documenting in the multiple systems that they use. So we're able to bring that value as well. But yeah, your instincts are right. That's a very good question.
We do have another question that's just come in. You talked about ROI during your presentation and revenue generation and volume increase. But in your experience, could you drill down a little bit more and kind of look at hard ROI and soft ROI within your experience, what you've seen within a health system or a medical group?
Sure. So very good question. We have seen on a tangible or a hard basis, we have seen that productivity of the physicians improves rather significantly. It can run on the low side of 10% improvement in productivity, which could be 2 patients a day to as many as 5 or 6 patients a day, if we assume 20 patients is about average for primary care. So we're seeing on a hard basis, there's no question that the doctors can see more patients, that access improves. There's absolutely no question. Low side 2, high side 4 or 5, maybe even 6, depending upon how busy. Now, the other tangible or hard ROI will be in revenue. So as I mentioned, we're capturing a better note. We're capturing everything that happens, and our certified coders are, we all know physicians are not expert coders. It's not what they want to do. It's not what they're trained to do. They don't like doing it. So we provide that coding advice to them based on what's documented. So we're seeing a 2 to 3% uptick in revenue. It takes about 1 patient a day to break even on this service. So there's actually improved revenue after paying for service. Now on the softer side, quality of life of the physician is significant. Physician satisfaction, physician engagement improves, and their overall quality of life has improved. And those things are kind of hard to measure, but we have also seen patient satisfaction going up. Now that can be measured and has been measured, and it has improved as well. So that might be more of a semi art, if you will. But it's a very good question. We're really proud of the impact that it can have on access and on revenue and productivity, et cetera. And Rodney has a comment as well.
Yeah, Steve, I really love this question because the beauty of this IRA virtual clinical assistant is in the diverse nature of its ROI. Jim hit several of them, both the objective and subjective ROI returns, but there are so many different things that had huge impact in an organization. Things like more robust clinical documentation, more robust, more accurate note by every provider in the organization that's on the service, the variability and the inconsistency, the timeline to sign off, of a clinical note, the timeline to close out charts. That's a challenge that many administrators have across the country, is getting their providers to sign off on their notes and bill the charges within a 24-hour period. We see vast improvement in that. Jim alluded to the fact that we see a 2 to 3% uptick in coding as a result of these more robust notes. But what really happens as a byproduct of this service, certainly if it's bundled with the coding solution that we provide, is the virtual elimination of risk for over or under coding by your clinical staff. Physicians and advanced practice clinicians are not typically trained formally as coders. They learn on the job, on the fly, and it's not really a place where it goes back to the same aspect of moral injury I referenced earlier. It's not really their passion in life. Their passion is in laying hands on and applying clinical medical decision making for their patients and on behalf of their patients. Coding and typing are not two things that they go through a decade of training to be able to perform every day. So what you end up having is, in the more robust node and the more accurate coding, you end up with a substantially lower amount of compliance risk in regard to your billing practices as an organization. We could go on and on about the benefits of the service, but a more robust node that's easier for the provider, makes the patient happier in the encounter experience, opens up access and the ability to actually grow your patient panels with the same number of providers. You get multiple layers of benefit here in one solution point. And we believe it can be impactful on a grand scale for every system in America.
Well, I think that was a very comprehensive and great answer. Jim and Rodney, we don't have any questions pending, and I'm going to turn it back over to you if you have any closing remarks. But I'd be remiss if I didn't tell you, thank you so much for a great presentation, wonderful product, and we really appreciate you taking time to go through this. So we're going to turn it back to you for any closing comments.
Thank you, Steve, and thank you, Chris. Yeah, I just wanted to say thank for the folks that have joined us today, and I also would say that we went through this at a very high level. We have created this from the perspective of helping our physicians, our advanced practitioners, and the care team. We have multiple ways that we can drive value to that care team. In the physician's world, provider's world, we're focusing on that. We would love to be able to dive into this and be able to show you more on how this might work for your organizations. Implementation is easy, and frankly, from a financial perspective, breaking even on this and driving the ROI is a no-brainer. And the other thing I would mention is start off small. We really like to be cautious. Start off small, prove the concept. It's been proven around the country. Prove it to your individual doctors, prove it to your system. Give us a call. We'll find a way to get you started on a small scale, and just prove it to you and your doc, whether you're inpatient or outpatient. We have seen significant results in a hospitalist environment where it improves the CMI because you have better documentation, so coding's improved. Do discharge summaries in a hospital environment, and we've seen it in an inpatient. We've talked a lot about that ROI. So a lot more to say, but in a 1 hour time frame, we didn't want to dive too much into it. Please give myself or Rodney a call at the number that's on the screen, and we'll get back to you promptly. And thank you, DFW Hospital Council, Steve and Chris. Thank you so much.
Thank you all.
Thank you. Thank you very much.
Appreciate it.